Welcome. I'm Dr. Alex, one of the organizers of the 2026 Central Texas Parkinson Symposium. This presentation is one of 9 talks in a series created to inform, support, and empower individuals and families living with Parkinson's disease. You can watch these sessions in any order. Follow what feels most helpful to you. Links to the other talks, along with additional resources and ways to connect, are available in the description below.
Good afternoon, everyone. It's really my pleasure to be here today. I am Dr. Okwara. I go by Chi-Chi, so feel free to say that. It's my privilege to talk to you about some mental health concerns that can come with Parkinson's. And I will go through my slides, and hopefully we'll have plenty of time to kind of discuss and answer questions or figure things out together. Okay. All right. So in the medical terms for Parkinson's, there are things we call cardinal features. I think all of you know what that is. You know about the tremors, which is involuntary shaking, the slowness in movement, muscles feeling very stiff even when you're at rest, and trouble keeping balance. I'm not really here to talk about that because these are the things people see when you talk about Parkinson's. I am going to talk about what I call the invisible features, right? In mental health, we're so used to feeling misunderstood because people typically will suffer in silence. You don't see someone and know that they suffer with depression or anxiety. They're not things that are easily visible or even understood by people, even people with the best intentions. So I'm going to talk about depression, apathy. I will explain what that is later, anxiety, irritability, and psychosis. Psychosis is a term that basically describes any kind of a break in how you perceive your reality, okay? And these are all things that people with Parkinson's struggle with. Depression actually can be way more problematic before we notice those cardinal features that I talked about. So when we look back, a lot of people that are subsequently diagnosed with Parkinson's notice that they experience depression even before they start experiencing the physical problems. It's pretty common, like up to 50% of people with Parkinson's disease are subsequently diagnosed with clinical depression. And it's not just an emotional reaction to getting a diagnosis or a stressful event. There are actually reasons to suspect that this is part of the disease of Parkinson's, right? It's not just an emotional response. So the formal term for one of the more common depression types is what we call major depressive disorder. And when we talk to you, we're asking about different symptoms or different things you might be experiencing that stays on for a sustained period of time. So our cutoff is more than 2 weeks, right? So experiencing these things consistently for more than 2 weeks at a time. Usually characterized by feeling really down, sad, hopeless most of the time. And you don't have to have a clear reason for this. Like things could be going well in your life and you just feel down most of the time. Losing interest and pleasure in the activities you would normally do, right? So people around you may notice that if you typically liked to golf, it just doesn't seem that interesting or fun anymore. So these are kind of the 2 main things that we look for. And then recognizing that depression is not just feeling down, it affects different things. You experience changes in your sleep, so trouble falling asleep, staying asleep. I think a lot of you are kind of nodding, you may recognize that. Changes in your appetite, which goes along with your weight. Feeling a lot of low energy or feeling slowed down. Restlessness or slowness in your movement and speech. Trouble concentrating on making decisions. So you may notice that you lose your train of thought easily. You can't really organize your thoughts. Feeling worthless and overwhelmed by guilt, like you're just so hard on yourself now, right? Like you can't really give yourself the grace to kind of navigate life, which is not always going to be perfect or going well. And then depression is a risk for suicide, right? Like you can have thoughts of wanting to end your life. So these are the things that when your doctor talks to you, they're sort of trying to figure these things out. Now, in Parkinson's, this diagnosis can be particularly challenging, right? Because if you look back, a lot of those things come with the disease, right? So people with Parkinson's often experience trouble with sleeping. There's a lot of slowness in movement that is part of those cardinal features that I talked about. So this can be diagnostically challenging, which is why hopefully where we come in to try to sort these things out, right? Because the slow facial, like the slowness of the muscle movements that you have with Parkinson's can sometimes hide emotional expression, right? Which makes that suffering even more invisible. Like people are not really gonna understand how you're feeling. The slowness of movement can be confused with low energy and fatigue, right? That comes with Parkinson's. It's part of that cardinal features that we talked about. So what do we really look for when we're talking to you to try to figure out if there's clinical depression? We're looking for the emotional suffering, right? So, sadness is not really a cardinal feature of Parkinson. Like that sadness that you feel internally cannot really be confused with other things. That hardness on yourself, like excessive guilt, blaming yourself for things you normally not blame yourself for, feeling like a burden to people around you. And then that hopelessness that can come with depression should not really, those are the things that can help us sort through the physical things that can be confused with depression. So earlier I mentioned apathy. So depression versus apathy versus anhedonia. Like to go through and kind of explain what those words mean. So apathy is pure lack of motivation, right? Like you don't feel like doing it even if you could enjoy it, right? And then anhedonia is a reduction in your pleasure. Like you could do it, but you don't really enjoy it the way you used to. So that we see in depression. So you can have apathy without depression, but most people that have depression will have apathy and loss of pleasure. So it's kind of a terrible combination, right? Like you don't have the motivation, and even if you could do it, you don't enjoy it. So you can kind of picture how problematic this could be, right? So depression, we're basically looking for that emotional suffering, the apathy, like low motivation, and the reduction of your ability to like enjoy things. So really terrible combination. Hopefully you're kind of getting a sense that depression is not just feeling sad. Like someone is not just having a bad day, their day-to-day is really affected. Like there's difficulty in being able to like navigate life all of a sudden. So just to kind of, have a little visual of the depression, apathy differences. So we on the medical side, we actually need to know if you're dealing with depression or apathy because the way we treat you would be different. Like the treatment options are a little different. So it's important for us to recognize that. So with depression, the emotional suffering, like the sadness should be there. It's part of the clinical symptoms that we look for, this, the criteria we look at. Someone can have apathy without the emotional suffering, but still problematic, right? Because the person doesn't have motivation to do things. The guilt is part of depression, like the excessive guilt, but you don't necessarily have to have that with apathy. Hopelessness comes with depression, but not with apathy. With their motivation, both are reduced, motivation is reduced in depression and apathy, but in apathy is very reduced, right? And then when people are depressed, the emotional pain is present, right? They have that emotional suffering. But someone that's apathetic or has apathy doesn't necessarily have the emotional suffering. When that comes in, we're dealing with depression. And the pleasure is reduced in depression. But in apathy, if you actually get them to do something, they will tell you that they enjoyed it, right? So it's almost like they need someone to kind of, push them a little. And as a caregiver, what do you observe and what do we hear? With depression, the person is sad, they're emotionally pained, that emotional suffering is very apparent to the caregiver. Apathy can be very challenging to navigate for not just the person dealing with it, but the caregivers, because you can't really understand why this person is all of a sudden they don't have the motivation to do the things they would normally easily do. So you're human too, so you're kind of wondering why does this person seem lazy all of a sudden? I don't like lazy because we can't fix lazy, right? So when my patients come in I just feel lazy. I'm like, no, we can't. If you're lazy, you wouldn't be here, right? You're trying to figure something out. But this is what you see and you perceive, right? Because there's just this lack of drive that comes without the emotional component to it, but still very problematic too, right? Because it affects your day-to-day functioning. So moving on to anxiety, right? So anxiety is actually a very helpful emotion when it's manageable. Anxiety is something that allows us to survive, right? So from a survival standpoint, you need a little bit of anxiety to anticipate things that kind of allow you to problem solve and navigate through life and adapt to things. But when you have an anxiety problem or anxiety disorder, like we call it, it becomes unmanageable. And these are some of the things that we look for. So you have an excessive worry, fear, right? So in certain anxiety disorders, you fear everything. All of a sudden, you worry, you can't stop worrying. You worry about you worry about normal, a variety of things, but to an excessive degree, you can't let it go. You may notice that you feel more on edge, right? Your body feels tense. It doesn't really seem like it takes much to set you off. So people may notice that you're more irritable. From your perspective, it seems like you're getting upset for no reason. People never get upset for no reason. So I kind of debunk that too. If you're getting upset, you're upset for a reason. We just need to figure out what it is. And then once again, anxiety also affects people's ability to concentrate. You can have what we call panic attacks. So panic attacks, anxiety attacks are very physical reactions that people can have when they're very anxious. Their heart can race a little, race a lot. They might feel like they're having a heart attack. Actually, a lot of people that have panic attacks, they don't come to the psychiatrist first. They go to the emergency room because they can have trouble breathing, feel like their heart is pounding, their chest feels tight. Some feel like they're going to throw up. So they can have very physical, real, painful symptoms, okay? And this can be very disabling. What do you do when you don't feel good and you think that something is setting you off? You get away from it, right? It's very instinctive. If I touch something hot, I'm not going to try to figure out why it's hot. I'm just going to remove my hand. It's sort of a survival mechanism that we all have. So a lot of people that experience anxiety, one of the things that kind of worsens their ability to live through life is they just avoid places because they're trying to figure out why they're so upset. So let's say if you had a panic attack at church, you might decide that maybe you had a panic attack because you were in church, so you stop going to church, right? And then maybe it happens again at a grocery store. You stop going to the grocery store. What does this do? Before you know it, you're kind of isolated to your home, right? And you don't necessarily feel better, but your mind is telling you that you got to try to survive or get away from whatever could be causing your suffering. Anxiety may worsen tremors, which, that is one of those cardinal symptoms that we talked about. And then with Parkinson specifically, we also notice that it may fluctuate, the timing of when people feel anxious may correlate with when their Parkinson's medications is wearing off, right? So that's something that's a little bit peculiar with the Parkinson's disease. And like the depression, unfortunately, is quite common. Like up to 40% of people with Parkinson's disease may experience an anxiety problem even before they develop the physical problems. And then I'll kind of spend a little bit time on this. I think I have maybe one slide on this because this is, the psychosis part, like I explained, is characterized by any kind of break in your perception of reality. So you may start seeing things that are not there, or people are telling you they don't see. This typically comes on in advanced Parkinson's. It's usually not we don't usually see it in the early stages like the depression, anxiety. And sometimes it may be part of the medication that you're taking for the Parkinson's. Sometimes you can overshoot a little bit, and it may kind of trick the brain to perceive things that are not really there. So important to talk to your neurologist about that, because oftentimes they might be the first ones to see it even before they come to us. The seeing things that are not there is usually the most common phenomenon, like is the most common thing that we see for the psychosis. But really it could be any sensory problem. It could be hearing, it could be feeling, it could be smelling things that are not there. And oftentimes people know that what they're perceiving is not real. So they're not unaware of it. So we call that insight, which is a little different from primarily psychiatric conditions. Sadly, in the primary psychiatric issues, people are not really, the insight is not very good. But in Parkinson's, the insight is that people can tell that what they're seeing is not real, right? Which is good because then you can verbalize that to someone. And then there's something that we call delusions. Delusions is basically when you have a belief about something that doesn't quite match the reality of what is, right? Thankfully, it's not as common as seeing things, but it can be very problematic and scary for caregivers because most times, the caregiver might be the part of the delusion, and that could really get in the way of that very supportive, helpful relationship, right? Because the caregiver is human too, right? It doesn't feel good for someone to have those thoughts about you, even when you know that it's not really true. The presence of this psychosis carries some risk, right? It can increase the chances of someone with Parkinson's being hospitalized, so being in a hospital setting, which is never really good for anyone. We do hospitals when we have to, but it's really not the best place to be, as all of you know. It can be a burden to the caregiver, which is a thing, right? So caregiver burden is absolutely a thing. So if you feel that, that's a whole different topic, but that's something that can be really hard to wrap your head around because you're obviously there on your own. This is a loving relationship, but at the same time, you're human with just about limited amount of capacity to do what you do. And then it can also increase the chances of someone needing to be in a skilled nursing facility because home can only provide so much, right? And at times it can be a safety issue. Like it might be unsafe for you to know, it might become unsafe to be at home. So we've kind of talked about these different things. So we talked about depression, how that is different from apathy, anxiety, and how we, on the medical side of things, need to really tease that out so that we can figure out what we can do to help. So thankfully, there are things that can be done that can actually help with these things, right? So we have medications and we have non-medication things that can help, and most times, if not all the time, they work well together. So it shouldn't be one or the other. So antidepressants, which I don't like a lot of psychiatric drugs names because they really don't do what they say. So being on an antidepressant doesn't like take away your ability to feel emotion. Like it's not an antidepressant. To me, anti means like, oh, the opposite. But that's what we're stuck with, and I can't change it. But antidepressants are drugs that we can use to treat both depression and anxiety, right? And these are pretty safe drugs, and a lot of them are quite safe to use with Parkinson's medication. So having someone that can manage like medications interacting with each other is something that we want to be cognizant of. But these are not; these are fairly easy drugs to be on. So medications that, so as you all know, one of the big chemicals that we associate with Parkinson's is a chemical called dopamine, right? So we sort of look at Parkinson's as low dopamine. That's sort of a simple way to look at it, but is one way that we look at it. So some medications that can increase your dopamine levels, and there are specific ones, not all of them, can help with that apathy that I talked about, right? So if you have apathy without depression, you might not need an antidepressant. Actually, antidepressants sometimes can make it worse. So it's really important for your doctor to like tease those two things out, which is why you want to talk to someone about it. So medications that increase your dopamine level can help with the apathy, but oftentimes by itself is not enough for the depression aspect that I talked about. If we're in the later stages and there is dementia, so dementia is sort of when you start having problems with your memory and remembering things, kind of organizing your thoughts, there are certain medications that are not antidepressants that can help with apathy, right? There are medications called antipsychotics. Here we go again with the anti. But they can also help with those psychoses that I talked about. Really, the point of this slide is to kind of offer hope that there are things we can do. So I just talked about all these things. Like, if you have this invisible suffering, it can actually be helpful to bring it up because there are things that we can do. So it's our job to kind of work with you to figure out what's going on and manage your treatments and, work with the rest of your team to make sure we're all on the same page. And then Dr. Armitage talked about how movement is almost always a good idea. In mental health, it is. Like, we actually, people study this and they have specific recommendations, right? So it's always funny to me that we have to study to kind of prove to ourselves that exercise is good for us, but we do. Multiple studies, actually. Movement is always good. I think a lot of conversation has been had about that, but from a mental health standpoint, at least 3 times a week of high intensity, like exercise, and exercise that kind of gets your heart rate a little up, can be very helpful for anxiety, right? And then for depression as well. Brisk walking when possible. Resistant training are exercises that basically like strengthen your muscles, right? So those can be very helpful too. And then there are mindfulness things. So mindfulness exercises with yoga. So mindfulness is sort of this idea of someone helping you stay in the present, right? So there are multiple ways to do that, but those can help with anxiety for sure. We know that. It can help with sleeping, and it can also help to manage depression. It's really not considered something that can help treat depression, but it can help you kind of manage the symptoms of it on a day-to-day basis. And then there are mind-body practices. If you've ever seen those videos where people are kind of doing like slow motion, like martial arts, so Tai Chi, Yin-Jong, those are kind of things that can be helpful also, not just for the physical problems of Parkinson's, but also for the emotional well-being as well. Psychotherapy is talk therapy, right? So, and this is not just talking to someone, although that's always very supportive, because sometimes I hear things, oh, I talk to my friend. Your friend can never be your therapist. So talk therapy uses some specific tools and ideas to kind of help you work through your thinking and your feelings, right? So it goes beyond just having someone to talk to, which is always helpful. And that's where the support group also comes in, right? So support groups are actually particularly evidence-based, meaning like they're strongly recommended in the mental and emotional well-being in Parkinson's disease because it helps with that isolation that can come about, which can even be worsened if you're depressed and if you're anxious, right? Because you're just trying to kind of get away and survive, but by doing that, things are worsening. And it can help enhance social connections, just to know that you're not out there by yourself. So we talked about medication, so pills, and then non-medication things, which are centered around physical exercise and talk therapy. So neuromodulation, just going to talk about two main ones. So neuromodulation are, when we give you, our body communicates with chemicals and electricity, right? So when we give you pills, we're basically sending like external chemicals to go in and, send a message, right? Sometimes we can do that with other modalities too, like we can do that with magnetic signals, which is what transcranial magnetic stimulation is, and is an approved treatment for depression, is very safe. Few years ago, this was not readily available. Right now, it is. So it's not so hard to get in to do TMS. And this can be particularly helpful because when you do TMS, you don't have to worry about multiple drugs. Like if you're someone that just hasn't reacted well to drugs, which can happen, TMS basically is something you do in a clinic setting. You're awake for it. You don't need to take any pre-medication. It doesn't hurt. You wear like a little cap. It kind of looks very futuristic, but not really. You can be sitting, watching TV, reading a book. You have a doctor that basically maps out the exact signals that they think would be helpful for you. Doesn't take more than a few minutes. The appointments are usually 30 minutes long, and you do it several times a week, and you go on about your day. So when we do this in clinic, people can come in, do it, and from there, go do something else. So it's very well tolerated, not invasive at all, not painful. The only pain that people may report is just the tightness of the hat, which most times we can work with, but is a very well tolerated treatment for depression. Electroconvulsive therapy is it's probably one of our oldest treatments in mental health, and people have a lot of misconceptions about it. It's basically a controlled electrical stimulation. So instead of going with a chemical, you're basically applying the electricity in a very controlled fashion. We typically consider ECT for severe depression just because of how invasive it can be. But it's a very effective treatment because people ask me if it's so good, why are we not offering it to everyone? We could, but it requires a little bit more commitment. It requires anesthesia. You go to a hospital for it. You need someone to take you there, bring you back. It needs a lot more support to do compared to transcranial magnetic stimulation. But it's a very, very effective treatment for severe depression, which is why it's still stayed around even over a century now. One side effect people may have from ECT is short-term memory problems, which is something else your doctor tracks. All right. And I will skip over this part, and I have some resources, information, but I think that's all I have, and I can answer any questions. Thank you all.